Good morning, everyone. My topic of discussion is Theil corneal dystrophy, which is a rare corneal dystrophy, inherited disorder that affects the cornea. It belongs to a group of subepithelial stromal corneal dystrophies and characterized by bilateral progressive changes in the cornea. It typically presents in childhood or early adulthood with symptoms such as recurrent corneal erosion, blurred vision, and increased sensitivity to light. It follows an autosomal dominant inheritance pattern. Coming to our case, a 13-year-old female presented to us with gradual progressive diminution of vision in both eyes with intermittent episode of pain since childhood with a strong family history, with no history of any past systemic illness, and the general physical examination and systemic examination were within normal limit. Coming to ocular examination, the best corrected visual acuity in the right eye was 4/60, in the left eye it was 6/60. The intraocular pressure in the right eye 19 and in the left eye 18 mm of Hg. The eyelid, eye wall, conjunctiva were within normal limit. Coming to the corneal examination, the cornea, we can see the superficial subepithelial honeycomb-like opacities, which is not extending to the limbus, and the rest of the eye were within normal limit. The ocular investigation suggestive of mild to moderate component of the dry eye. The pre-op investigation on slit lamp examination, we can see the superficial subepithelial honeycomb opacities, which is not extending to the limbus. AIOS suggestive of sawtooth pattern of hyperreflectivity in Bowman's layer, and confocal scan suggestive of hyperreflective material with homogeneous reflectivity, round edges and dark shadows within the basal epithelium. So based on this, we reach to our differential diagnosis of Rees-Buckler corneal dystrophy, which usually present with confluent irregular geographical like opacities at the level of Bowman's and superficial stroma, which is not present in our case. In Theil corneal dystrophy, it usually present with reticular subepithelial opacities with limbal sparing, which is present in our case. Granular dystrophy is usually present with crumb-like opacities involving subepithelial layers. Lattice dystrophy have refractile glass-like branching lines in subepithelial layers, and macular corneal dystrophies have irregular grayish-white flakes-like opacities at the stromal level with intervening haze, which is also not present in our case. So based on this, we compare our case to Theil corneal dystrophy according to IC3D classification, which shows the superficial subepithelial honeycomb opacities, which is not extending to the limbus. Again, according to Sibelman et al., the AIOS also suggestive features of the Theil corneal dystrophy. The confocal microscopy, according to the IC3D, suggestive of Theil corneal dystrophy. So based on this, we made our diagnosis of both eye epithelial stromal corneal dystrophy, probably the Theil corneal dystrophy. The patient underwent right eye superficial anterior lamellar keratoplasty under general anesthesia. This is the clinical picture post of day 1. And the AIOS post of day 1, we can see the regularity of the cornea. And histopathological examination, we can see the baby sawtooth pattern, which is suggestive of the Theil corneal dystrophy. So it is what is unique in our case, it is a rare condition which present at the younger age, and genetical and clinical diagnosis is essential. Clinical implication, the accurate diagnosis and role of imaging is important, and the surgical management is preferred in advanced cases. So take-home message is early recognition and genetical counseling are essential for managing hereditary corneal dystrophies. Advanced imaging techniques aids in the diagnostic, and SALC is an effective surgical option for visually significant Theil corneal dystrophy, and histopathological remains still gold standard. Thank you.
Thank you, Himanshu, for sticking to the time. You said genetic counseling is important. Can you tell us something a little about that? Because this is the part often you people miss. Whenever you see a patient of dystrophy, always call all the sibling and do have a look what's there, right? So Himanshu?
So most of the corneal dystrophies are autosomal dominant dystrophies. They are progressive generation to generation. So proper counseling and is essential for the management.
Any comment from experts?
Yes. Honeycomb appearance in the middle, central or periphery?
In the middle, sir.
Middle, not central, but...
Central and paracentral, but not at the limbus.
Okay. Yes.